It affects my practice when some of the nursing staff, and as somebody who takes pride in still being a nurse, sorry to say that I don't believe in direct entry midwifery. I believe you should be a nurse first. How to put that in.
Uh-oh.
Annie knows I'm passionate about that. But it bothers me as somebody who's a nursing educator and who knows what they learn and know what is taught, what they're tested on the boards, that they don't even assess why your patient's here. I mean, just before I saw some lady who they had overbooked me for a third time, 3 patients in one time slot. And the nurse could have saved this patient from waiting to see me for 2 hours because I was so backed up. And for a lady whose appointment should have been, she needed a leap. And if the nurse would have triaged her and saw why you're here and looked at her papers and would have said, this is the wrong clinic. And saved this lady 3 hours. That's really frustrating. Or when a patient has postmenopausal bleeding and they should anticipate that you're going to be doing a biopsy and do all the things ahead of time. Do I have the instruments in my room? If the patient is of childbearing age, getting a pregnancy test, getting her prepped for it. But no. It's really frustrating.
So what do you have to do? And so they're sitting in front of you and you realize,
I'm getting the history, postmenopausal bleeding. Then I'm like, okay, go give me some urine. And that's now 10, 15 minutes.
Right.
Checking my room, which I shouldn't have to run around for instruments.
Right.
Or
they
bring me like a different tray that doesn't have a sound in it, or doesn't have a tenaculum in it, or a dilator.
Right.
Especially when, also anticipating if she's postmenopausal, I might need a dilator. And the poor lady's in stirrups, and I'm waiting 15 minutes for a set of dilators.
Yeah.
It's so frustrating.
Yeah.
For the patient as well as me, and then every patient who's waiting behind.
Right. But you have, it sounds like you have amazing clinical skills.
I'm doing this a long time.
I was going to say, I mean, we're trained as midwives in the basics of this.
Right.
But you're working at a completely different level at this point,
yes.
Right? What has made you choose to stay here at Jacobi? Because you could probably take your skills anywhere.
Not really. I mean, I'm very lucky. Not that I make a ton of money, but I do think that advanced practice nurses with experience are terribly underpaid. And one of the oncology attendings left and went to a big private institution on Long Island, which I won't name. And they really wanted me because her and I had done research together, and she was going into a new program that was starting a fellowship, and they wanted her to do research, and they wanted someone to do research. They wanted a qualitative researcher. So I kind of hit all the check boxes of what you wanted. I said, we're talking about starting a survivorship program, you want to do this. And they offered me a salary that was just like an insult. So, yes, I can go other places, but...
Right.
And I still have my attachments here.
Attachments to what?
My patients. A couple of the staff. I mean, there's a couple of the PCAs who were just fantastic. It really is an easy commute to my house. Dr. Zinneman gives me pretty much a lot of leeway and respect. But also when I call him, like I live biopsying an old lady and she's hemorrhaging here, and I need another set of hands. He kind of knows that if I call him, you better come running. That I'm not comfortable here. Yeah. So there's a lot of different things here. I mean, and some of it, like I said, is the patients. Some of them I have patients here who I took care of when I was here the first time, and now I'm seeing them again. In a different phase of their life, which is really kind of cool. And I have new established patients that I've been seeing now for 5 years that I've been here.
And when they come, are they asking for you, looking for you?
Oh, yeah. Totally.
Yeah. I mean, to me, I know this is my bias, but that's because of your midwifery model.
I've always said this.
Them. Yeah.
When people talk about my working in oncology, I'm like, it's the same philosophy.
Yeah. Can you, if you were to share with a group of young midwives, what would that be?
I tell them, having women in all phases of their life, it's still the same philosophy. even when I'm taking care of a long-term oncology patient who's coming toward the end of her life, and it's very sad for me, knowing that this might be the last visit that we have here when you're a patient of mine, and we talk about these things. I mean, it's the same thing, I think, when you're a midwife and dealing with a poor outcome in midwifery, too. It doesn't mean you run away from the patient. And and in these difficult settings, like in oncology, even our patients who do well, a lot of our patients have a lot of sequelae, especially with sexuality, which is one of my research interests that I was doing with the attending who left here, because there's such a need, especially in the inner city population. We don't have a survivorship program here, which I still would like to try to get if we get the resources. And when we started talking to women about sexuality after a cancer diagnosis and after treatment, so many of them, it's like when you bring up the question, they're like, oh my God, I can't believe you're asking me. And it's like we're talking hours about sexuality.
I would imagine for some, you're the first person to ask them.
Yeah.
Or bring it up.
Or to bring it up even before treatment, to be like, you're going to get radiation and it really might harm your vagina. We want to save your vagina. And I come out with like a big dilator. And they look at me. I'm like, I know it looks funny, but this is really important. We're going to give you a little bit of, estrogen cream, which, in the oncology world, people think you're in oncology, you give estrogen. Like, we love estrogen in oncology. Unless you have an estrogen-dependent cancer, we're giving you estrogen. When we're concerned with things like, and I'm trying to forge a relationship with actually the medical oncology to send us their younger women to maintain their fertility. It's like, did anyone talk to this young lady about her childbearing plans? And how is this going to affect it? A lot of insurances don't pay for things like egg freezing. But in a case like this, where they're not just doing it because, I want to party some more, and I want to still have babies, it's like because they're going to be getting treatment that might decrease their ovarian function. I mean, so midwifery care, it's that same philosophy of looking, what are your goals for your treatment? What are your goals for your care? How is your family coping? What resources do you need? And if you don't want them, that's fine too. And if you say, I really don't care about sex right now, we have to stop that conversation. Maybe that's not important. I mean, I've had patients, it's interesting, tell me that having had a cancer diagnosis has kind of almost brought them closer to their partner. Because instead of dealing with the act of sex, they became more intimate.
Right. Yeah, that's pretty powerful.
Very powerful.
Yeah. When did you decide that you weren't going to attend births anymore? I mean, I think you're so interesting because you're, like, it's such a specialty you're in.
I watch birth videos and I want to cry. I miss it terribly.
Do you have grandchildren?
I don't, but I can't wait to actually catch my own.
I was going to say.
Although knowing my kid, she's going to want the epidural with the first contraction, but I will not let her have that. I don't like the climate. I can't practice like this. I'm really old school midwifery. But I came from like a high-tech L&D nurse where I didn't know any better. But then thanks to the old midwives who trained me down at Woodhull Hospital, I learned to be very hands-off. I became to trust birth. But I also know when something's wrong. And it's like, you have twins and you're VBAC. No, you're not doing this. But for somebody who's otherwise normal, I'm really very anti-epidural. I have a saying that I teach to even my nursing students: nothing is benign. How do we think if we put an anesthetic in somebody's spine that's going through the placenta that it's not affecting the baby? Like, my dream would be to get a tremendous NIH grant because I really think autism is related to all the intervention we do in birth. I do. I might be crazy, but I really do. So that's why I'm not catching babies. I just don't like the climate.
But was it like a moment or event, or was it just sort of a general feeling?
It was when Nancy DeVore left, and we had a very strong midwifery service then, and it wasn't that way anymore. And basically, Montefiore and Jacobi had the big divorce at that time, and everything changed. We went from having really good clinicians, physician colleagues who we worked really well with, to like laborists who weren't used to working with midwives and would come in and start managing, and I was just like, I don't want to do this anymore. I fought for this. And at the same time, things were changing and they needed more people in the outpatient setting, and our roles expanded in